All right, so I believe we're recording. Hey everyone, thank you for joining us today, and we just wanted to welcome and thank Dr. Samantha Curran for DPT for coming today and answering all of our questions regarding women's health physical therapy. We have some questions from our closed private Facebook group and then some questions that I got through social media of questions that people had for Samantha, and we're going to kind of just do a Q&A and go from there. So first of all, if you're looking to find Samantha, you can find her on the Foundational Concepts Facebook page or website. Foundational Concepts is actually a women's health specialty physical therapy clinic here in Kansas City. There's a couple of locations. We've got one downtown. We've got one kind of in the suburbs. Overland Park is what it's called. And so one on the Missouri side, one on the Kansas side, and that's where she is at. I'll let her tell you more about herself, but she is actually going to be going on maternity leave here, I think today, for the next couple of months, and she's going to be having some twins. So anyway, congratulations, and thank you so much. Do you want to give us a little bit about your background?
Definitely. So I graduated from KU and with my undergrad in health, sport, and exercise science. And from there, I kind of went down the personal training route. And I did that for 2 years. And I worked with athletes of all different ages. So I worked actually in a physical therapy clinic, but we did some personal training, post-rehab patients, things like that, and kind of just gradually got them back to their sport, whether that was just running or whether it was more the CrossFit, whatever that may have been, strength training. And so we kind of just worked with a whole range of age groups. And then from there, I went on to get my CSCS, and I was able to utilize that just a little bit before I decided to go back to PT school. And then when I went to PT school, I assumed I would just work with the athletic population, and that was kind of my end goal. And so when I went to PT school, I had a definite change in my career path whenever I was introduced to pelvic floor physical therapy, just realizing what difference that could make in people's lives, not only in just our regular postpartum or pregnancy or whatnot, but then also how that can integrate into the athletic population as well, and how many of our athletes are affected. I can't tell you how many athletes I worked with prior to going to PT school that, we would do jumps or whatever, and we would have leakage, and everyone just kind of assumed that was normal, myself included. We just that was part of it, and we went from there. So it was really nice to start seeing how we could kind of bring all of that together. And that's how I really got into pelvic floor physical therapy, and kind of just went from there. And now it's kind of taken off to seeing orthopedics and pelvic floor, and eventually hoping to get back to working more with specifically athletes and pelvic floor dysfunction as well.
Very cool. That is so awesome. So it's so needed. Plus, I like the crossover between orthopedics and pelvic floor because, like you said, a lot of times the people that are having pelvic floor issues are also wanting to be athletic or are athletes or doing like a little bit higher intensity stuff. So like, where does that person go, and how, and making sure that they get the correct care for what they need, which I think is super, super important, because a lot of times too, then you have two different, you have either orthopedic PT or you have pelvic floor PT. And so to integrate the two, I think is really special, because that's where I think you can really solve some problems. At least in my experience, I feel that way. I've seen both kinds of PTs, and the integration is huge. So hats off to you, and that's going to be super cool. All right, so let's dive into the nuts and bolts of what we're going to talk about today. So our first question is just dealing with postpartum women, and the question is, what are the most common types of issues that you see as a physical therapist with women postpartum coming into your office for the first time? And these women specifically, I guess, to give you more background on the question, these are specifically like athletes that were, previous athletes or people who were really athletic before they had their baby. And Definitely. Now they're just coming to see you. So what are the main types of issues that you see with these types of women?
So I would say the biggest thing that we see postpartum, and especially in our athletic population, are incontinence. For one, urinary incontinence, and then also diastasis. I feel like those are two that are very common. And then I would say the third one would probably be like pelvic pain issues, almost too much tension, which seems silly and random. After delivery, we think everything should be loose and weak. And it can still be weak, but we can still see some pain issues with that as well. And I would say the incontinence is definitely the number one, just because we typically try and get back into our sport a little bit too soon. Before we've actually strengthened what we need to strengthen. And so we start to see, we get back into, we try and kind of pick up where we left off, which our body's not typically ready for that, obviously. And so that's normally where we start to see the frustration and things like that. So that would probably be our number one. And then, like I said, the abdominal separation or diastasis, I feel like that is one that is also a really big one we see in our athletic population, again, because we're, that should be healed about 8 weeks postpartum. If it's not, then we know that there's something, going on with that, that could use some treatment. And so we see people that will kind of push through that or try different workouts to try and get it back to where it should be or strengthen their core, but they may not be doing it appropriately. So I would say those are definitely the two biggest that we see.
Cool. And then with some of that, do you find that you don't see the patient until the struggle has already happened? Or let me ask you this. How often do you see these athletes before there's a problem? Or is it mainly always after the struggle has occurred?
Yes, that's a really good question. Typically, it's after the struggle has occurred. We would love to see patients, 8 weeks postpartum, 6 to 8 weeks postpartum, every person, whether you're an athlete or not. Yeah. Just because I definitely think there's a need for it. And I think a lot of women, they don't know, for one, that there can be treatment. But two, I think that we get so caught up in everything else that's going on. There's not very many muscles in your body that you tear or have that much trauma to that you don't have to see a specialist for. And so I feel like oftentimes it's, we try and get back to our sport, or we try and run, or we try and pick up our kiddo even, whatever that may be. And that's typically when people realize, I can't do this. I'm completely peeing my pants, or I try and lift my kiddo out of the bathtub and I can't do it. I'm worried I'm going to drop him, or I can't carry the carrier, whatever that may be. And that's typically, those functional tasks are the ones that typically get them in here. But also if someone is a big athlete beforehand, if they can't participate in their sport, that's another big driver to get them to come in.
Okay, so here is the $1 million question. The next one. Wrong. And I'm saying this in words because I know that this is not an easy answer, okay? But yeah. I'm going to just say it in words that moms ask all the time, okay? How long does it take my diastasis to heal?
Yes, we were actually just talking about this question here at the office. Okay. So my answer to that is not a clear answer. Typically, normal healing time for a diastasis or diastasis, what we look at is about 8 weeks postpartum. Okay, so if you're 8 weeks postpartum and there's still some abdominal separation there, then you more than likely need some treatment to get things to activate appropriately. So that's just kind of the normal tissue healing time for if it's going to heal on its own. Mm-hmm. So after that 8 week mark, if there's still separation present, or there's still kind of doming of the abdomen, or, notable weakness, or we can't participate in our sport, or whatever it may be, our functional tasks, we typically see patients for about 6 to 8 weeks or 6 to 8 appointments, just to get that muscle recruitment kicking back in, to get, train the body to know how to activate those muscles. And is it, the obliques that aren't kicking in? Is it the transverse abdominis? Is it the pelvic floor? What is it that's the weakest link that we need to really address? And so we check all that to see which one tends to be the main culprit. After we test for that and we kind of figure out which one it is, then we would start the treatment progression from there. Gotcha. So we want to work on, closing it here in the office. Can we functionally activate and close that off? Right. So with that being said, that 6 to 8 week mark, we can get things to engage typically within that time frame. Some are a little bit, some only take 4 appointments, some take more than that, just kind of depending on where we're at with body awareness, kind of what kind of trauma we've been through, how severe the separation is. Mm-hmm. And then from there, we have the fun part where people are like, I still look like I'm pregnant, or I still have this little pooch when I stand up or when I relax or whatever that may be. So connective tissue, which would be like the linea alba, takes 300 to 500 days to turn over. Okay. So, and that's if we're consistent. So if we're consistently activated during our normal daily activities, then we might see, if we are done nursing, we aren't pregnant again within that time frame. That about 2 years, you'll start to really see, okay, now cosmetically the changes are occurring.
That is such a fantastic, I don't know, mind-blowing statistic. 300 to 500 days to fully turn over the tissue. That's huge.
Yes. And that's really, that's if we are diligent about keeping it activated. So if we're not training it to constantly turn over that way, then it's going to be slower.
Wow. That's huge.
That's kind of our answer. Again, it's not a straightforward answer. No. And again, everyone's very different. And it depends, are we seeing these patients 8 weeks postpartum, or are we seeing them 8 years postpartum?
Yeah.
Based on what's going to happen.
Mm-hmm. That kind of takes me into our next question, which is actually my question, which I had to throw something in there. But okay, so the latest, and I know we've talked about this personally, but I think it's good for other people to understand too. We've talked about some of the newer research talking about how we don't necessarily need the diastasis to come back together fully, but we need it to be functional. And so then moms are like, well, I still have a separation, but is it functional? So my question to you is, how do we know if, according to the newer research, you're functional, or I would say, in my opinion, functional is kind of healed. Like, if you're functional, you're healed. But what do we then say to those moms who are concerned that they still have a separation?
Definitely. So I usually tell my new moms up front, whenever they come in here for the first appointment, we do an assessment, and then I'm always very open. Cosmetically, we aren't going to be able to make all those cosmetic changes. Will it get better? Yeah. And functionally, we'll be able to do our tasks, whatever that is. But I'm always very open up front, because I don't want people, and when I first started out, I feel like I didn't give them that direct answer up front of, hey, we can't fix the cosmetic piece. If so, everyone would be coming, right? Right. But so what we're looking at is, I'm very open and honest about that up front with my women. And so I always tell them, our goal is to be able to get you back to your function. Again, daily activities, exercise routine, whatever that may be. And, we may not get it completely closed, but we want to make sure that it's firm. So if we're kind of palpating, above the belly button or at the belly button or below, we want to make sure that we're having a kind of a hard backstop, rather than where our fingers can sink in pretty deep. And so we're looking for one of the two things. Can we close that off, or do we have a firm backstop? And usually whenever you get that firmness, you're still functional, even if it's, 2 finger spaces, which is technically still considered pretty normal. Yeah. But that 2 to 3 fingers, is it firm? Are we able to get that, strength through that? Rather than when it's really soft, we're not going to get that strength through there. So we may still notice back pain or incontinence, or other issues that come along with that.
Gotcha. Very cool. And like we were talking about too, different people needing different type of stresses based on what they're doing. So like, for example, if you're picking up a toddler that's 30 pounds, or you're trying to clean and jerk at the CrossFit regionals and you want to clean and jerk 225 pounds, that's a very different stress on the body. Both are equally important, but each person's going to differ greatly in how much stress their basically core can handle, right? Like, can their pelvic floor and core actually tolerate the stress? And then we also, I think, want to test based on what we're trying to do, right? So if somebody is trying to go to the CrossFit regionals and they're having these problems, like, what movements can we test and then reassess? And I think you're crucial in that, because you have the orthopedic background as well, so you understand movement and bigger loads than just a 5-pound weight or a 20-pound toddler.
Definitely.
So, so being able to assess diastasis depending on the stress that
yes.
the person has to endure, right?
I totally agree. I think it's all about kind of what their particular goal is or what their particular function is. And for every single patient, that's different. And that's where seeing somebody like yourself or a specialist of some sort that understands that everyone, every treatment's going to be different. And every patient or client is so different in what their demands are.
Right. But in like a good thing to think about too is that you have seen diastasis kind of heal or be functional in all of the ranges, right? Like,
Definitely.
I know recently, I think Lindsay Valenzuela, like, she has a 2-year-old and she's back to competing in the CrossFit Games. So she went through years of pelvic floor PT, or a year and a half, I think, or something crazy to get back to what she's doing. But she can now hold that she doesn't have the doming when she's doing these crazy workouts, which is really cool to see. Like, if you put the work in and you do what you're supposed to do, you can get better. So it's not like a death sentence to all working out for the rest of their life,
Definitely.
In some cases, you do have to take a few steps back before we can go forward.
For sure. And I think that's the frustrating part for a lot of patients.
Yes. Okay, so here's our next question.
Yes.
What does recovery look like for a mom who has a very high training age versus a mom who has never worked out before? So are you seeing any, and this is more of like just what you have observed in clinic, do you see any differences or basic benefits between somebody who has been working out and somebody who has not been working out?
Definitely. That's a good question. So I think it kind of depends on the situation, for one. I've had new moms who come in that haven't ever worked out, and their tissues are awesome. They've had 7 kids in 8 years or, whatever, and they have no abdominal separation. They just have a little bit of incontinence. We see it for 4 visits and they're fine, which is great. I think a lot of that comes from genetics. But I think the biggest thing with our population of those who have worked out for a while before versus those who haven't is the discipline and continuing with their home exercise program. I definitely feel like those who have had the history of working out or getting back in, or wanting to get back to their sport, they're much more driven in that regard. And so they're very much more disciplined in what what we ask them to do. They're compliant. They're the ones that you have to kind of pull the reins back a little bit to say, hang on, I only want you to do this many. Whereas other times we see patients that don't have that training background. And so it's like pulling teeth to get them to be compliant all the time with their home exercise program. And I think compliance is a huge thing that we run into, especially, we only see our patients once a week.
Yeah.
And so we always tell patients, we're not going to heal you by seeing you only once a week to do your exercise program or whatever that may be that they need to do.
Right.
So I would say that's the biggest thing. And then also just the way our system works, the way the nervous system works, that neuromuscular recruitment. We typically, if we've been an athlete for a while, we understand our body connects a little bit quicker. We're able to engage muscles that are hard to activate, but before pregnancy or before delivery, they were already active. And so it takes a little bit less time to kind of get that recruitment. Whereas if you haven't been active, it takes a little bit longer to find that.
Right. And I think that's a good point. So like the 2 main things that you get out of working out postpartum would be, sticking to your exercises and being able to recruit more muscle or get it recruited faster. But also one misconception I think I hear a lot is I'm working out in pregnancy, so I'll have a good labor. But working out does not equal necessarily a good labor.
Exactly.
I think that's really important, even though working out is important to stay healthy. If you've currently been working out, I don't think that it's going to help you bring anything back together. Or, well, like you said, other than doing your exercises and hopefully getting some more muscle recruitment, but it's not the magic tool to necessarily performing better or having a good labor postpartum.
Definitely. And I think working out during pregnancy is great. I mean, obviously we definitely promote that. It's not going to hurt anything, right, which is awesome as long as you're safe about it and you're obviously doing something that you're not starting new workout programs.
Right.
But I do think that sometimes we do get that misconception of, I've been working out my entire pregnancy, I should be fine postpartum.
Yeah.
And I think we see a lot of frustration with that too, of people that will come in and I worked out up until, before I delivered. hard, or I ran marathons late in my pregnancy, or, whatever.
Yeah.
I'm still having these issues.
Yeah.
But again, it's
labor wasn't easy, even though I was training for it. But I don't know if there's any way to train for labor.
And yeah, everyone's just
so different.
For sure.
Yeah.
Yes.
Anyway, okay, we're gonna shift this over to incontinence now a little bit. So incontinence is definitely a huge buzz in CrossFit right now. We do have a couple of important coaches who have been addressing the issue, which I think is really cool. There's also been some people out there just dismissing the fact that peeing is not normal, which is interesting. But anyway, so talk to us a little bit about, incontinence during exercise, lifting, or jumping, and why does this happen?
Definitely. So incontinence during exercise is huge. We see it all the time in here. During exercise, coughing, sneezing, laughing. We hear about it from, our patients will come in and we'll see them for a few visits and they'll get better. And then they're like, I don't know why my mom won't come, or my sister won't come, or my friend who works out with me won't come, or, whatever it may be. If they realized if they could fix this problem, I think they'd really come. And so it's always just funny to see the wide variety and all ages. It doesn't matter if they've never had kiddos with workouts, or if they're, I had a lady that was in her mid 70s come in for incontinence issues with workouts. Mm-hmm. And so we see them from literally all over the lifespan. Whenever we look at why is that happening, it can be for several different reasons. So one of the biggest things that we see too is kind of the pressure changes. So we find a lot of, with our lifting, heavy lifting especially, and even sometimes jumping, we're holding our breath, or we're doing a lot of valsalvating. And that will obviously cause an increase in pressure in the abdomen, which pushes down then on the pelvic floor. Postpartum especially, that pressure's got to go somewhere. So whenever we think about just a normal lift, we might see people that maybe throw out their back or whatever that may be. And that's that pressure, it has to go somewhere. So if we're not breathing out or exhaling, that pressure buildup is going to go to the weakest link. And so typically postpartum, that weakest link is our pelvic floor. And that's where we're going to start losing urine. So whenever we think about it with lifting techniques, that's typically what we run into. Jumping can be the same thing. We can find it with breathing, can typically be a huge improvement for that, and just generalized weakness. So doing pelvic floor strengthening. But then also we see a lot of muscle tension, especially in our lifters, that we'll find, we have pelvic floor muscle tension, which we think, hey, if we have tension or we're tight, we shouldn't leak. But whenever we're tight in that area, we're finding that we can't actually contract when we need to. So we land on impact and our pelvic floor can't do its job because it's been contracted for so long. So there's typically a few things that we're looking at with treatment to see exactly what's causing it. And we assess it on the first appointment to figure that out. So then we can address the treatment from there on out. But those are typically the main things that we see with stress incontinence.
Cool. And I think about too, can stress incontinence happen with males as well?
Yes.
Okay.
Yes. We can see it, and we kind of see it all over the board. Typically in our males, when we see it, it's a lot of times with prostate issues, prostatectomies or things like that. But it could definitely happen.
Or I was just thinking leakage from the rectum too, as opposed to just urine.
Yeah. Yeah. Definitely.
I feel like it would be a different world if all these males were leaking, and then, but since it's just the ladies, we're trying to make that. But it's getting here slowly. We don't see it. We don't see it nearly as commonly. I would say most of my male patients that I see, it's typically post something with the prostate. It seems to be. And whether that means that they just aren't coming in unless that's the case, or, I don't know. So what is a good strategy for somebody who's trying to improve their problems with incontinence? Definitely.
So this could go kind of multiple ways, but for me, what I would recommend is obviously if we're having a lot of incontinence and your doctors are obviously telling you, do your Kegels, try those, whatnot. I think it's like 80% I can't remember the exact number, of women do Kegels inappropriately. Okay. So whenever we say, do your Kegels, if you're not having success within a few weeks, you should probably go see somebody, because odds are you're probably not doing them right. And if you are doing them right, it's probably not what you need. So if you're having incontinence, but you're also having any pelvic pain, typically that's a sign that there might be some muscle tension that's actually causing the issue. With that, we recommend lots of stretching, relaxation, more almost like yoga type techniques, yoga stretching, kind of opening up the pelvis. And that way we can relax down, a lot of breathing. And I would say, any type of incontinence, whether you're having pain with it or not, I think that breathing is a huge component that can help to kind of coordinate the pelvic floor with the diaphragm. And then, of course, with workouts, making sure that you're not breath holding, seeing if that can help too, to not strain through the pelvis, strain through the abdomen, and see if we can release that pressure in a different way.
That's awesome. Yeah, and I think I spent 21 years of my lifting career holding my breath doing the Valsalva maneuver, which helped me this much. And then the last year and a half postpartum, figuring out actually how to breathe and engage my pelvic floor and core while I'm lifting, leaps and bounds different. Wish I would have done that about 21 years ago.
Right.
Not many people talk about it, and if you're a kid starting out lifting, you're not going to talk about the pelvic floor, right? So
Exactly.
maybe that's something you learn with experience, but hopefully we can get some of these athletes before too much damage has been done, right? And they learn about proper breathing techniques and the ramifications of different breathing styles and how that affects different parts of their body. I think is really crucial. So very cool on the incontinence piece. So another big thing, what we have going on with our women is prolapse. So I work with a number of women who have prolapse, so this is definitely key. Our first question for you is, does prolapse last forever? Because I know if people have prolapse, they think, will this ever go away? This is so uncomfortable.
Definitely. So, again, that's one of those, I feel like everything with the pelvic floor sometimes is kind of like a answer.
Everything, training, lifting, coaching.
Right, exactly. Like, so with prolapse, it depends. So it depends on, are we having the prolapse postpartum, and how severe is it? So if we're postpartum, we're nursing, we're lifting, we have maybe just a slight prolapse, a grade 1 or a grade 2. Can we see that improve? Of course. We can do, strengthening, things like that, change in body mechanics as hormones start to change, the elasticity changes in the ligaments. So that all kind of just helps with tensing that up. So you'll see maybe a change in 1 grade or so. So maybe from a 1 to a 0. So just a slight movement of whatever organ it may be, back up to its baseline, or from a 2 to a 1. As we get older or we're further postpartum, it's harder to see changes. With that being said, you may not see those physical changes of, I still feel like the organ is kind of bulging down. However, symptom-wise, that can improve. So we can still improve, the pressure sensation or the leakage sensation, or whatever that may be, with exercise and with therapy. We obviously want to change body mechanics. We want to figure out, what are we doing that's causing it? Was it just pregnancy, or are we straining for bowel movements, or are we straining while we're lifting? Whatever that may be. And so we want to make sure that we're changing that and addressing that. And then can we strengthen kind of from the bottom up? So strengthening those pelvic floor muscles, because we can't physically change what's holding the organs in place, right?
Right.
And then what we find too is, if patients are grade 3 or 4, to where the organ is actually bulging out of the vaginal opening, we may not be the best candidates for that. So can we strengthen some, and then we're going to, prepare them for whether they need to have a pessary or they need to have surgery at that point. But those are you don't see those very commonly. Usually those are they're operated on before they get to us.
Gotcha.
But the grades 1 and 2, you can typically see quite a bit of relief in the symptoms, which is normally what you're going to see postpartum, is a grade 1 or a grade 2. And then we can definitely see that we can strengthen, we can change body mechanics, all that fun stuff to get rid of the symptoms.
That's super interesting, because
from that.
Think about too, like, okay, grade 1 and 2, there might be some things we can still do, but then, like, when do you need to go see somebody who specializes in pessary or surgery?
Yes.
Like grade 3, 4.
Yes. So grade 4 is typically going to be, you're going to need surgery, typically at that point. A grade 3, it kind of just depends on the person. what they want to try. Some people are really against surgery, so they want to try pessary. For some, a pessary will work. For some, it won't. And then some of our even postpartum mamas, they at a grade 1 or a grade 2, if they feel like, oh, it's just not getting better quite yet, then they like to try a pessary because it does give them that relief. They can still do their functional activities, but they can still strengthen. It's kind of like a temporary brace. So they, use it while they're lifting or whatever it may be, but they're still using their proper mechanics until they get a little bit stronger, and then they may not need it anymore. But again, everybody's a little bit different in what they prefer.
The hormones are kind of regulated in the body. So like pessaries, as far as I've understood, are not great for nursing moms because you're still changing tissues. So
yes,
so much. Yeah. So it's almost like you kind of need to wait until you're done nursing to see, will this improve? Will the tissue actually come back or help strain or stabilize?
Exactly.
You go maybe get fitted for a pessary.
Yes, because with the pessaries too, as they fit them, they fit them to you, and so they want to make sure it's comfortable. So as your tissues change, you may notice that 6 months later, it's not very comfortable anymore.
Yeah. Okay, cool. Very cool. That's super helpful. Okay, now we're going to move on to back pain. So our mamas, can you tell us a little bit about why our mamas are experiencing back pain postpartum? So
there can be multiple reasons. So obviously hormones play a huge factor in that, for one. Two, what we find, back to the hormones, I guess. So we find that we have a lot more laxity. So whenever we have that laxity, everything's a little bit weaker, not quite as stable. That itself can cause back pain. When we think about being pregnant, how much everything stretches out, right? All those stabilizer muscles, everything has to stretch. And then we lose all that stability from baby after we deliver. So now we're really weak. Our core is weak, our ligaments are weak, everything is just kind of hanging out. And so not only now are we weak, but we're also carrying around a baby, or we're trying to change position, or we're trying to nurse, or we're trying to, whatever that may be, just hold the baby, rock them to sleep. And we usually put ourselves in a compromised position. So we have all this weakness and laxity, and then we're in a compromised position. And all that just because we're doing that day in and day out. Our entire world is below us, right? So we're always looking down, we're always bending forward, and just kind of hanging out, whether it's over the changing table, over the crib, or the baby's on the floor, whatever that may be. We're just putting a lot of strain on our back. Other things that we see too is, if we do have any abdominal separation, again, that's something else that's going to help stabilize the core. So if we don't have that stability in the front, we're going to have that weakness and pain in the back. So there can be a lot of different things. Also labor itself. Some people, we have an epidural, things like that. We can find that we may have back pain from that, or from the position that we're in, because we may not be able to feel that we were uncomfortable or whatever that may be. So it can be multiple different things, but I would say the biggest thing is postural, and just that position that we're in for so long. We don't even realize it because we're constantly taking care of somebody else.
That's awesome. So if somebody is having back pain, how long would you recommend, like, if it doesn't go away within a couple of days, a couple of weeks, go see Women's Health PT? When would you recommend they come to your office?
Definitely. So we typically wait about 6 to 8 weeks postpartum before we see patients, just because that way everything's healed. After delivery, everything, all the bleeding is stopped, all that fun stuff. And then if we're still having, depending on, how, I guess, tolerable it is or non-tolerable it is, because some back pain can be normal, right? But if we're to the point where if we're super uncomfortable, there's no reason not to come in and get things checked out. What is our pelvic floor doing? Because that's, again, a stabilizer. Right. So if our pelvic floor is not kicking in at all, we're having back pain, can we stabilize that pelvic floor? Because it's going to help stabilize the tailbone, which is the base of the spine. So we have to make sure that everything from pelvic floor on up is kicking in and engaging how it should. Cool. So I think it just kind of depends, again, like on this, on the severity of it, or what function, are we not able to do our functional tasks? Or is it something where, if I sit like this, my back hurts. Okay, well, maybe change our posture. Try that for a week or two and then see if that improves it. If not, then definitely call and get an appointment. And it may take 1 or 2 appointments to figure out, hey, this is what's going on. Let's change that and I feel great. And that's all you need. whereas other people may need a little bit more,
Cool.
depending on what the issue is.
Great explanation for why some moms would have back pain after having a baby. That's awesome. So lastly, the last question I have, I don't know if I sent this one to you or not, but is tailbone pain. So I have a couple moms who are experiencing tailbone pain postpartum. So is this something that they should see a pelvic floor PT for?
Definitely. So we do see a lot of mamas postpartum with tailbone pain. And I actually love seeing these women shortly after delivery because I feel like this is something that goes missed. I can't tell you how many people I see that they're like, I had this pain after my first delivery, now I'm pregnant with my second, and it's back during pregnancy, and I'm worried about what's going to happen postpartum. But they just assume, oh, it's probably just normal. So tailbone injuries are typically, or pain is typically a sign that, there's something going on. And whether that's pelvic floor tension, pelvic floor weakness, whether it's something, in the glutes or alignment wise, it could be multiple different things. But what we find is that depending on, we always want to find out with those women, what was their birth like? Was it a very fast birth? We think, oh, great, the baby's out, everything was quick, all of a sudden. But that's kind of like a whiplash to your tailbone, right? Because everything is kind of springing forward and then springing back really quickly. Was it a long delivery? Was baby just kind of hanging out on the tailbone for a while? So now we have like a strain on those ligaments. So kind of which one, what is it? Or was there, was it either of those? And then we find too, when we check pelvic floor, maybe the left side is really tight and the right side is really weak. So we kind of have a pull internally to one side or the other. And so those are all things that we can take a look at to see what is going on, what's causing that pain. But it's definitely something that can be debilitating. I mean, it's uncomfortable having that tailbone pain, sitting, walking, standing. Everyone's kind of different, what they need to do or what their symptoms are. But it can definitely be something that's very frustrating when you can't sit in certain chairs, or you go out to dinner and you can't sit there with your husband, or, whatever, because of the pain.
And I can imagine like the first few months postpartum and you're just sitting there feeding a baby for like hours on end and your tailbone is in pain. That has to be like the most excruciating thing ever. Because I feel like you're just sitting and sitting and sitting, and then, oh, that would be bad. So,
Definitely.
Cool.
Definitely.
Well, I think that wraps up our questions for today. My only other thing I was thinking of as we were chatting is, okay, so say our mamas are not in Kansas City and they can't come see you or one of your colleagues. Is there a website or a resource where you can find women's health physical therapists, like online or anything?
Yes. So I recommend going to what's called the Herman and Wallace. It's Herman Wallace website. So hermanandwallace.com. And they have Find a Provider. And through that, you can seek out different providers wherever it is that you're at. And so I believe that we are all on there. And then there's multiple different providers all over the country. And so if you have questions for them, typically if you call up to the office, they'll be able to talk to you and just kind of touch base with you and see, you can see if that'll be a good fit for you or whatnot, depending on your symptoms. Whether you talk to the person at the front desk or you're actually going to talk to the therapist will depend on the clinic. But that's always something that you can definitely check out. You can also check out through the APTA women's health providers to see who they have available as well. Depending on if you can't find something through Herman Wallace, that would be the next place I would take a look at.
Very cool. That's awesome.
Yeah.
All right. Well, thank you so much for taking the time to answer all these questions today. They're super helpful.
Perfect.
Yeah, I think that'll do it for today. If we have anybody who has more questions, we'll just have them send a message, and maybe we can do a part 2. A little later. But yeah, this was fantastic. So
Excellent.
you guys haven't yet, check out Foundational Concepts Physical Therapy, their website, and Samantha's on there. And also, they have a Facebook page, which is also a good resource if you want to ask questions or see what they're doing in their clinics or any of their research that they've found. So definitely check out Foundational Concepts on their Facebook as well. All right, well, thank you so much. I'm going to let you go. Enjoy your maternity leave, and I can't wait to see these babies.
Yes. They'll be here before we know it.
Oh, I know. It's going to be awesome. You're going to have so much fun. No.
I know.
At least
I
you
know.
know about all these things because you work and see them on a
Right.
day basis. So you're like, oh, I know what's going on versus us
Right.
sitting back here like, oh my God, what's happening? Yeah. So you're informed. That's very good. Awesome.
Yes.
All right.
Exactly.
Well, I'm going to stop the recording right now.
Perfect.